Hello, thank you for joining us today. We're here to talk about an issue that affects each and every one of us at some point in our lives, the quality of the health care we receive. It's been more than 15 years since the Institute of Medicine published To Err is Human, a report showing that tens of thousands of patients die each year from medical errors that could be prevented. Much has changed. Heart attack patients, for example, are far more likely to get aspirin and beta blockers within 24 hours of admission, and pneumonia patients are generally put on antibiotics within 6 hours. But some quality experts, policymakers, and consumers are also frustrated that change has been too slow. A recent study in the Journal of Patient Safety, for example, estimated that the numbers of people dying from preventable errors are much higher than originally estimated, in the several hundred thousand a year. Our panel today will talk about what has been accomplished and what else needs to be done. We have an excellent group with us to discuss this topic. Peggy O'Kane, the President and CEO of the National Committee for Quality Assurance, which accredits insurers and medical providers that meet specific standards. Mario Molina, President and CEO of insurer Molina Healthcare. Deborah Ness, President of the nonprofit advocacy group National Partnership for Women and Families. And Mark Smith, founding president and former CEO of the nonprofit California Healthcare Foundation. We're going to start with a few questions from me to each of our panel members, then we're also going to open up for questions from the audience. If you would like to ask questions, please tweet them at hashtag NCQA25. Again, that would be hashtag NCQA25 if you would like to ask questions. This year marks the 25th anniversary of NCQA, which convened this conference. So Peggy, we're going to start with a question for you. What are the 3 or 4 major accomplishments of U.S. healthcare quality in the last quarter century?
Well, I think the first one may not sound like an accomplishment, but we actually have quality on the national agenda, and we understand that quality needs to be improved. And when we first started out, I think there was an assumption that we had the best quality in the world. And, you know, nobody really knew what that meant. So just getting quality on the agenda has been a very, very important accomplishment. We also have national systems of quality measurement. You talked about hospital safety. We've got lots of hospital measures collected by various parties, and they matter. We have 171 million people who are in plans that are reporting our healthcare effectiveness data and information set, our national quality metrics. That enables consumers and payers to figure out which plans are keeping people healthier or making them well when they have diseases and so forth. And then, you know, I mean, people actually have improved the health of Americans through measurement and accountability. So, for example, diabetes complications came down by half between 1990 and 2010. So there's also very important work been done on the organization of health services. Our patient-centered medical home program now has more than 43,000 clinicians. How you're organized makes it possible to deliver quality health care, which ultimately delivers better health.
Thank you. Mark, as someone who helped shepherd and fund the quality movement in the past couple of decades, you've seen a lot of changes, some of which have definitely been for the better. But what areas, in your opinion, are still ripe for action? Where have things fallen short?
Well, first of all, I think I agree with what Peggy said. There's still lots of healthcare in America for which we don't have particularly compelling scientific standards of quality. So, for instance, misdiagnosis. One of the things that is most troubling for patients and clinicians alike, we don't have very good measures for when a diagnosis was missed. Secondly, we don't still have a very good handle on the locus of quality. So when NCQA got into the HEDIS business, the promise or threat, depending on your point of view, was that health plans were going to be active entities that would influence quality. They would construct networks, so patients were no longer free to go to any doctor they wanted to, and they were going to oversee doctor practices, so doctors could no longer do whatever they wanted to expect to get paid for it. So that was kind of the notion behind HEDIS. Well, now we find these new sorts of organizations, medical homes, ACOs, bundled payment contractors, to which our understanding of the locus of quality has shifted. And so there's a new need to pay attention to those things. And frankly, if you take, for instance, a woman who has breast cancer, she may have a medical oncologist, a surgeon, a radiation oncologist, someone who did the diagnosis, and for two different women, they may have two completely different teams. What entity does one attribute the quality of the outcome? So there's still lots of work to be done in terms of a much wider swath of American healthcare for which we need to develop persuasive and compelling measures of quality, and we need to think about the new forms of organization, the new sites of care. We're still in some ways counting quality by how many doctor visits did a patient make. Well, doctor visits are no longer a very good measure of quality. So there's still, with each evolution of healthcare, there's kind of new frontiers of trying to find the locus of quality and trying to find compelling and persuasive metrics for that quality.
So it sounds like we're going to need to continue to develop these measures and what we're looking at as we move along. Mario, as an insurer, you've been affected, I'm sure, by the increasing focus by the federal government on quality care. How has the increasing focus of the federal government on quality care impacted insurers?
Well, thanks, Julie. I think it's done a number of things. I think getting back to what Peggy said, the first thing it's done is it shifted the discussion away from simply being about cost to also being about quality and how do we create value. I think the second thing it's done is it's created standards so that we can compare one health plan with another. In the past, when we first started doing this, there were no standards, and so people reported healthcare quality, but you couldn't compare one plan with another. They've also tied funding to quality. So in many of our state contracts, for example, there are programs to incentivize the plans to provide quality care and reward them for that. Contract awards are now tied to quality. So unless you can demonstrate quality, your chances of getting a contract are less. And then finally, report cards. Because we now have report cards for both Medicaid and Medicare that allow patients to shop and compare between health plans. And all of this has been done more with carrots than with sticks. No plan wants to be at the bottom of the healthcare rankings. No doctor wants to be at the bottom of the rankings. And so this kind of healthy competition has helped to promote quality and get everyone competing to do a better job.
So Deborah, it sounds like we've got a lot more quality information out there right now. Mario just mentioned report cards and other things. Do consumers have more quality information than they did 5 years ago? And secondly, how good is it, and what else needs to be done?
So I could actually fill the hour talking about what else needs to be done, but I won't do that. I will say that I agree with Peggy and Mark and Mario that a lot of progress has been made, and there is a lot of measurement information out there. However, we're not yet at the point where I think we have all that much measurement information that is very useful or usable by consumers, by patients and families. And you can see that in a number of ways playing out. So, for example, there are lots of different folks doing reporting on quality. If a consumer were to put those reports together, you'll find that those reports might measure different things, and it's very hard to get a picture of really what the quality is for a particular institution or a particular system. It's not helpful to the consumer when they can't actually figure out why there's no overlap between who's ranked well in one report versus who's ranked well in another report. So that's a problem. And some of these reports are more accessible than others. But probably the most important thing from a consumer point of view is that the types of measures are really in need of evolution. And we've made a great deal of progress. When we first started measuring quality, we were still convincing people you could measure quality. And now today, we're no longer doing that, but we're doing the work of trying to get to better and better and more meaningful measures, especially for consumers. So, you know, for example, in the early days of measurement, you had a lot of focus on measures that were process measures. So they may have been very helpful in driving quality improvement, which is critically important. But door-to-balloon time, or whether or not somebody got their beta blockers, or mammogram screening rates may be less important or compelling to a consumer than knowing what the survival rates are in different institutions, or what the complications rates are, or what the infection rates are. And we're seeing more and more focus on outcome measures. And as we continue to evolve, I'm seeing more and more focus, and NCQA has been leading the way on putting more energy into developing measures that depend on feedback from patients. So measures where patients can tell you about the experience of care they've had, or measures where patients report on their own outcomes. So the question is not just, does the doc think that hip or knee replacement was effective, but can you as a patient walk up and down the stairs, and do you feel better? Is the quality of your life better? So that's a direction that I see the measurement world moving, and that will make measurement much more meaningful to consumers and patients and families.
Deborah, and this may also be a question that Peggy may want to weigh in on as well, but you mentioned that this can be confusing and that there can be different reports that show different things about the same provider. So it's very confusing for consumers. What would you say, how can a consumer tell which of these reports, report cards, star ratings, A to F grades, all these different things that are out there, which ones, how do you tell if it's reliable? What's a reliable report?
Well, I think at this point, it's not that hard to help consumers understand who the reliable sources are. The bigger problem is really that these different sources may be measuring different things, and there's no way for the consumer to put that whole picture together. So if somebody's looking at how well a hospital's doing in terms of infections, but somebody else is looking at how well they're doing in terms of outcomes from heart surgery, you might get two very different results. They're both valid, but if you're trying to decide whether that's where you want to have your cancer treated, neither of those pieces of information may be what you need. So it's not just about the credibility of the source, but it's also about figuring out how to make the kinds of things we're measuring more meaningful to consumers.
And Peggy, did you want to weigh in on that one as well?
I do. First of all, I think that we're all eager for the future to be here and to have much more information, because Deborah's really right. We are missing a lot of very important information. But we're very proud of the work that we're doing on patient-reported outcome measures. As Deborah said, we have a proposal right now to do measures for patients with cancer and how well their side effects are managed and so forth. But I do want to go back to the point about process measures, which I think people tend to think of as not as good as outcomes. I mentioned that diabetes complications have been cut in half. That is a result of many, many people working to do well on the process of care measures of diabetes, which were heavily evidence-based. And so managing the numbers for diabetes results in less blindness, strokes, heart attacks, etc. And ideally, we want to have such small numbers of those that they're not really measurable. So we have to find the right balance between structure, process, and outcomes.
And Julie, if I could jump in and just amplify on what Peggy just said, I couldn't agree more. And I would say, as a consumer advocate, I think about measurement, quality measurement, as having three key purposes. One is to drive quality improvement. So the kinds of measures that Peggy just described have had a huge impact on the quality of care. There's another reason for doing quality measurement, and that's accountability. We want to make sure we're paying for the right things. But the third is, okay, we also want to give consumers information that helps them make good decisions. And different measures are needed for those different things. And we're slowly evolving, I think, to a place of getting to more meaningful measures from the perspective of the consumer end user. But we still have a ways to go.
And Mark, did you want to weigh in on this as well?
Yeah, I guess I'd like to make 2 points briefly. One is that I think until relatively recently, professionals have tended to kind of poo-poo patient-generated measures as mere bedside manner. And everybody has an anecdote about somebody who was a really bad doctor whose patients loved him because he had good bedside manner. But 2 points. First, there are some things that are important, that are unequivocally, uncontestably important to patients that you can only find out by asking patients. If you think it's important that patients understand their treatment, understand the side effects, felt treated with dignity and respect, there is no orifice you can cannulate to get that answer. You have to ask patients. The second is there are wide swaths of medicine and more coming where the clinical outcomes are ambiguous and varied. And so starting back long ago with the work of Jack Wenberg and others with the Foundation for Informed Medical Decision Making about what do you do for prostatic hypertrophy, it may be important to one patient for this outcome, and it may be important to another patient for that outcome, which is why this issue of the development and promulgation of patient-centered measures is so critically important, is because professionals have one definition of what's important. Did I choose the right antibiotic? Was my scalpel right on the linea alba? But a patient may have a very different sense of what's important to him or her as the outcome of that clinical encounter. And so that's why I think development of this area is really critically important to move this field forward.
Mario, the federal health law created these online marketplaces where consumers can shop for insurance, they can compare plans. To date, there's not a lot of information on there about the various quality of the plans or the providers within those plans, but that is supposed to be coming. Different states are working on it, and the federal government has some requirements for next year. In your mind, what are the important quality measures that plans should be rated on? What should consumers know? Should it include information about, let's say, the percentage of out-of-network costs that consumers might see, or the claims denied by the insurers? What are some of the quality and other measures that health insurers should be held to on these exchanges?
Well, I think that the measures are going to evolve over time, but I think initially some of the things that people are really going to care about are, as you mentioned, out-of-network costs, what does the network look like, and really access measures. It's great to have insurance, but can I get in to see a doctor when I need to? I think those kinds of measures early on in the marketplace will be very important. Later on, people are going to be more focused on quality and outcomes. Things like, what's cancer treatment like in this particular plan? How are they doing on prevention? But I think in the first year or two that these quality measures come up, it's going to be dominated by things like access and ease of getting services. And I agree with some of the previous speakers. I think that a lot more of our measures, especially for consumers, need to be consumer-oriented. You know, whether we treated someone properly with a beta blocker for an MI may not matter to the average patient. But can I get in to be seen? Can I get the medications that I need? Those are the kinds of things that, especially early on, are going to be important in the marketplace.
And Deborah, do consumers use this information now? I think I've read some things that not a lot of folks look at quality measures or ratings when they're picking a plan or a provider. What do we know about whether consumers use this information?
I think, first of all, consumers are not a monolithic group, and you would see that different types of consumers are going to be more comfortable with some of the information and reports coming out than others, and I think we also are still in the nascent stages of learning how to make this information really accessible to people at the point of decision making. But I honestly think the more important impact of quality measurements so far has been on improving quality and in helping us to figure out how to pay for reward care more effectively rather than driving consumer decisions based on quality. And I want to try to knit together some of what the prior speakers have said. I think we're in a time where there's a major paradigm shift going on. The healthcare world is recognizing that we're moving from a system of volume to value, that we need to pay for quality and outcomes. That's a real major paradigm shift for our system, which used to just pay for visits and procedures. But with that paradigm shift, I hope comes another paradigm shift, which is that consumers have to be co-creators of the new value-based system that we create. Because it's hard to imagine all of this work we're doing and getting to the better health outcomes we want without consumers buying into this new kind of model of care, these new payment strategies, really wanting to be part of an ACO or a medical home. And we're going to need to make sure that we have measures that help consumers to see that actually some of these new payment models are in their interests and are delivering better care along the lines of what Mark talked about. That's a new field of measurement. It's another area I know NCQA is active in, but it goes to the importance of making sure that we actually involve the consumer voices, patients and family voices in the creation of measures if we want them to use these measures.
And Peggy, would you like to also weigh in on the question of the consumer's use of these measures?
Yeah, I really want to give a shout out to CMS, the Medicare program, which for Medicare Advantage plans, those are the health plans that people can choose when they enroll in Medicare, has a rating system with stars. And they very cleverly are awarding more money to plans with 5 or 4.5, which are the highest rated plans, so that the plans can offer more benefits like eyeglasses or hearing aids. And so they both have information that's easy to understand. It's complicated under the hood, but they see symbology of good quality, and they also get better benefits. So it's been a way of making this intelligible to people and of driving more market share to the higher performing plans. It really is working. There's very good evidence that people are choosing the higher rated plans, probably because of the enhanced benefits, but maybe also they don't feel they have to trade off between what they're paying out of pocket and what they're getting in terms of quality. So I think this has been a huge change and a huge step forward, without undercutting what Deborah's saying about the real importance of having the patient help us design quality measurement.
I'd just like to remind the audience that you can tweet questions in, and again, the tweet question would be to tweet it to hashtag NCQA25. You know, we were just talking about consumers, and we've heard a lot in recent months about security breaches and privacy issues. How are the needs of researchers and providers to collect this quality data being balanced with concerns that consumers' private data is protected from marketing or other purposes not related to quality? Mark, I wonder if you could maybe start with that one. You might want to hear from some of the others too. How is this information being used, and how do consumers know that their private data is not being used for marketing or other things?
Well, frankly, they don't. One of the great paradoxes of the current age is that people who are supposed to be real data jockeys, who are supposed to be good at security, report every day that their databases have been hacked and penetrated and compromised. And so it's clear that for a long time, concern about this issue of privacy has been part of what's held back consumers' confidence in digital health. So I think there's a very real question about the methods, the standards for privacy and protection. At the same time, there's kind of also a group of kind of privacy fanatics for whom I think the benefits of digital health are always outweighed by a strict emphasis on privacy. And for most of us, in our treatment of our data with banks and with retailers and with others, we make an implicit or explicit trade-off about how important is our privacy versus the convenience or the other benefits that we get. To the extent that the system now can increasingly integrate the data that's available to us with information that's useful to us and with benefits, I think people will come to accept this in the same way that we've come to accept it with our financial lives, none of which absolves anybody from the responsibility of much better job in security and protection of our data across the board, whether that's in healthcare or any place else.
Mario, how can we address the pervasive quality gaps that exist for minorities, low-income groups, and other at-risk groups?
That's a really good question. Julie, one of the things that we talk about here, and this really started with Dr. Kevin Park, who's our head of quality, is that the way that you do that is that quality becomes everybody's job, and it's about breaking down barriers to access. I think by promoting access, we will see a lot of these disparities go away. Because I think that at the root of the disparities are problems with access to care. Everybody wants the best for themselves and their families, and I think that if everyone had the same access to care, we would see a movement in those kinds of scores.
Peggy, would you like to weigh in on that one as well?
I would. You know, one of the things that we notice when we compare across plans or across different organizations where we have quality measures is that there are always plans and others that cater to a poorer population who are outstanding. And what we find there is a kind of a relentlessness in terms of pursuit of quality. There's a lot of debate now about risk-adjusting quality measures. You know, so if I'm taking care of a less well-educated population, should I get kind of a handicap, like a golf handicap? I think that makes me profoundly uncomfortable. Although I think that we need to acknowledge that if you're facing a bigger challenge, maybe there ought to be some kind of a case management fee that's added into your payment or something. But I really want to say that I think we have organizations all around the country that are proving that we can eliminate these disparities, but it takes a lot of hard work.
You know, that brings up an interesting debate that's ongoing right now about we reward financially providers that are doing well according to these measures, and we penalize providers that aren't doing so well. And some critics of this have said that this is just making disparities worse, that the lower performing places are not going to be able to get better, and that this is going to cement disparities. And I wondered if any of you would like to weigh in on that debate.
This is Mark. Yeah, I'll say two things. First of all, it's interesting and a little bit ironic that there's a big movement in this country for quality, as represented by the people on this call. There's a big movement of people interested in disparities in health. And there hasn't, I think, been sufficient cross-pollination among them. Because if you think about it, starting 30 years ago, Jack Wenberg demonstrated that there were systematic and irrational variations in healthcare from one town to another. The rate of hysterectomy in town A versus town B. The rate of tonsillectomy in state A versus state B. And so on some level, the ways in which men and women are treated differently, straight and gay people are treated differently, white and minority people are treated differently, are just subsets of the irrational variation that we find throughout healthcare, whose answer is, as Mario said and as Peggy said, a relentless focus on quality and on systematic improvement for everyone across the board.
And Deborah, did you want to weigh in on this as well?
Yeah, I was going to say that from the patient point of view, the goal of looking at socioeconomic factors is important in order to be able to see where the disparities are and to be able to address them. It should not be a vehicle for penalizing those providers who are working with the hardest to serve populations. And so there needs to be, I think, some very serious thought put to how you both assess those variations that are due to disparities, but also provide the resources that providers need in order to do the work of meeting the needs of those populations. I actually think that this also links to the discussion we were just having about patient-generated measures and health information technology. So the more we move toward patient-generated data and patient-reported outcomes and patient experience of care, the more we're reinforcing the idea that clinicians should know enough about their patients to be able to provide care and make recommendations for care that make sense for that patient's situation. And when we do work with consumers and ask them what they think they want most out of patient and family-centered care, they say, I want a trusted relationship with a clinician who knows me well enough to make the right recommendations for my life. So there is a role, I think, here for measurement to help impact the relationship between patients and clinicians, and we can meld that together with the right kind of measures. And HIT, I think, can facilitate that.
And Deborah, how would you weight those two various things? Because there's been a lot of debate. Patient satisfaction measures are very important, but are they as important as outcome measures? I wonder if you could weigh in on how you would rank those against each other, or merge them together.
I think, you hear me saying patient-generated data, because that includes both the experience of care as well as how people feel about how the care ultimately did in terms of their outcomes. And experience of care is a little bit different than satisfaction. Satisfaction can be, did you like the color of the walls, and was the valet parker nice to you? That's not what we mean by patient experience. Patient experience, well done, goes to the heart of whether people got the kind of care coordination that they needed, whether they got the kind of information about how to take care of themselves that would help them get better or stay healthy. That's patient experience of care that has a relationship to outcomes. So that's important. And patient-reported outcomes actually are essential, especially as we think about the more complex patients we're serving. As the population gets older, and we have more and more older complex patients, as we have more and more people with comorbidities and multiple chronic conditions, you can have clinical outcome measures for particular conditions, but what if somebody has 4 or 5 different conditions simultaneously? You need a picture of how good their care was, and that picture is probably going to come from the patient's report of how well they're doing, more than it's going to come from some series of individual clinical measures. So you need both, but I think it's time, as Mark said earlier, for the clinical community to take patient-reported, patient-generated data more seriously.
And Peggy, would you like to weigh in on that balance as well?
Yeah, I think I wanted to go to procedures. A lot of people get lots of surgery in this country, and there are real differences in the outcomes of those surgeries. New York State has had a database on cardiac surgeries for many years, and it's really affected. Hospitals have made big changes as a result because nobody wants to be last, as Mario said. But I think also, there are many procedures where patients ought to be able to see the outcomes and have a choice based on who has the best outcomes. So, if you're going to have a hip replacement, if you're going to have your knee replaced, if you're getting cataract surgery, I think that these are areas that are ripe for outcomes measurement and for real good public information. And then also for the plans to use that information and maybe give more favorable conditions to those kinds of high-performing providers. I think ultimately we want the plans to be market makers in those areas of care and really drive the business towards those that really aspire higher.
Mario, the head of the hospital accrediting group, the Joint Commission, recently wrote of his frustration with the slow pace of change. He mentioned that there's still a number of problems. We still have wrong site surgeries. We still have lack of proper hand hygiene and things like that. But he said that current efforts have also focused too much on fixing preventable problems and too little has focused on the overuse of medical care. What is the best way to address that overuse question?
Oh, I think that's pretty simple. I think the best way to address the issue of overuse is to change the way we pay providers and change the incentives. We are still largely in a fee-for-service system, and when you reward doctors for volume, that's what you're going to get. You're going to get more volume. There's a bill before Congress right now that's going to change the way we pay Medicare providers, and I think that that is the direction we need to move in. Bundled payments. Payments tied to quality, payments tied to outcome, capitation payments, all those kinds of prospective payments that reward value rather than rewarding volume.
Is there a way to measure the impact of prevention on quality? Mark, I wonder if you could take that. Or Peggy?
Well, let me say, I think the answer is twofold. One, on clinical preventive services, there are abundant measures. We have many good measures of clinical preventive services, like screenings for cancer and so on, colon cancer, breast cancer. But on patient behavior, I think we're still not there. We don't really understand well enough how to influence patient behavior, and we know that patient behavior drives a lot of outcomes. I think part of the secret is in better health literacy. We have 90 million Americans, according to the Institute of Medicine, who are not health literate. They don't understand the most basic terms. They don't understand how their behavior is affecting their health and so on. So that's one of the frontiers. You know, having people, I mean, learning more. I think there are kind of analogies from behavioral economics about how to change behavior, and it's not always more information. It's learning how to help people motivate themselves and so forth. So that's one of the big frontiers, I think, for health plans in the future and for providers.
So if I can, Julie, let me also say there's, I think, a linkage between the last two questions you asked. Part of changing medical overuse, I agree with Mario, payment is important, but I caution us not to limit it to payment, because this is not a question of bribing doctors to act differently. I think it is in part a question of changing the professional culture, which is why things like choosing wisely are so vitally important. But it's also what Deborah's been saying about patient outcomes. To the extent that the healthcare system says to a patient, for instance, a patient with a terminal disease, rather than just, would you like us to do everything, says, if we give you this chemotherapy, the chances that you will recover function that you would describe as appropriate are X. The chances that you will be nauseous, sedated, uncomfortable are Y. My sense is people would make different decisions. Patients would make different decisions. And so to the extent that part of overtreatment is driven by the economics, but part is driven by the culture of providers and by the understanding, or perhaps lack of understanding, by patients about the real potential benefits and harms of their choices, I think we've got to be careful to include those in our toolbox and not leave it simply to paying people differently and expecting that they will go kindly in a different direction.
And Deborah, I think you wanted to weigh in a little bit on is there a way to measure the impact of prevention and, you know, this whole discussion. What do you think?
I think what our speakers so far have said is information is key. I mean, obviously you want people to have the right information about where they can go for the best care and the most cost-effective care. Certainly payment can be a valuable lever, both for providers, but also it's used to incentivize consumer behavior. But I want to say that if we rely on those two alone to change consumer behavior, we will not get where we want to go. And it goes back to my earlier comment about consumers needing to be co-creators of health and health outcomes. It goes to something very fundamental about the patient-clinician relationship. If a patient and clinician are in a relationship in which there is trust, in which there is knowledge of the patient's socioeconomic circumstances, in which there is the ability to have the kind of conversation that Mark just described, you will have very different kind of patient behavior than if you're just giving people information or just trying to use financial steerage. And a lot of times we hear people in the clinical world talk about patient engagement, and you know, if maybe there's the right tool or the right information, if only I can get my patients to do what I tell them to do, it'll all come out better, we'll have those better outcomes. And then you have payers who try to incentivize that through various kinds of insurance designs. But then you look at what we give consumers to make information with most of the time, and maybe we give them some cost information. Oftentimes we don't put that cost information together with the quality information. So if we're trying to teach consumers to think about value differently, or if we're trying to get consumers to really change their lifestyle or change their behaviors, I think two things have to happen. We have to start putting quality and cost information together and helping consumers understand value the way we're trying to get everybody else to understand it. And I think we have to focus on building that relationship between patients and clinicians so that there really is a willingness to trust what your clinician is telling you, and that leads to behavior change more than just information or financial incentives.
And Peggy, could you weigh in on how you get consumers more involved with this idea of measuring prevention and quality and cost and all that?
Well, I want to go back to some of the points that Mark has raised a couple of times about shared decision making. You know, it really is remarkable how little information patients are given often. They don't even know that there's a choice. So if they have cardiovascular disease and they went to a surgeon, they're likely to be prescribed surgery when actually there may be medical treatment available that's much less risky and has equivalent outcomes. But I think that when we have a payment system that's more where the alignment of incentives is appropriate, then you're more likely to have that. But, you know, let me just take it to another example. Childbirth. When I was having my children, women had taken back childbirth. It's actually very interesting to watch what's happened over those several decades. And things have gone in the other direction. And so we watched the C-section rate going up and so forth. And I wonder, and I know that Deborah's organization has been working on this issue as well, is there a way to take the paradigms that were developed when we took back childbirth in the 1980s and 1970s and broaden that to old age and to medical choices of old age? Can we take back childbirth again? Can we make it a less medical situation and a more natural situation? So I think that there are some things to learn from certain historical events.
Mario and Mark, I think I'd like to ask you this question. We've got medical home model out there. There's been a lot of efforts to try to get folks into medical homes, but the research has been mixed about the effectiveness. Is it still a viable vehicle for primary care?
You know, I think it is. I think that more research needs to be done, but we've done some pilot studies and we have seen some benefits. I think it's going to require doctors to change the way they practice. The concept of a medical home is really the concept of team care. It's not a doctor delivering this, but it's all the people that surround the doctor, and he's just a member of that team. In order for it to work, you've got to have IT systems to support it. You've got to have ancillary staff, non-physicians, that are also going to be involved. And that, I think, is really the key thing, and it's an evolution of the way that doctors practice medicine.
What's not working right now? What is it? What needs to be improved to get this model to work?
I think you need to get doctors to realize that the concept of the solo practitioner or the small group really can't accommodate the needs of patients anymore, especially as we get into more complex patients that have multiple medical conditions. It really takes a team, and we need bigger groups.
Peggy, do you have any thoughts on that?
Yeah, I mean, I think that, you know, the deployment of medical homes around the country has been very different from one situation to another. At the best, we see payers giving the medical homes a care management fee that allows them to hire people, you know, to build out that team that Mario was just talking about, and that enables them to have this relationship-based situation with their patients as opposed to a visit-based situation. So I think what we're seeing in the research is we're seeing lots of different ways in which the medical home is operationalized and the surrounding systems being quite different one to the other. There are also situations where payers will give to the medical homes information about people that need to come in for certain screenings, whose numbers are out of whack, or where there's some follow-up needed. So there are ways in which payers and medical homes can work together to get the best outcomes. But, you know, I always think of a story that was about 10 years ago one of our staff was visiting the Mayo Clinic, and he was listening to a focus group of patients, and it was people with diabetes, and this lady was saying, well, you know, I have to be good, because if I have to come in and see that nurse and tell her that I wasn't following instructions and my numbers are bad, it makes me feel really terrible for her. That's the kind of relationship, and that's the kind of, you know, getting the patient to understand their role in a very positive way that I think we need. That's what the medical home model really translates to.
So I have a caution here. I agree. I believe in the need for coordination in our over-specialized system. But the notion of medical home has gotten tangled up with advocacy issues about payment rates for certain specialties. And there's still a kind of physician-centric, provider-centric notion that I am in control of everything. I am going to coordinate this. If you think about the rise of retail clinics, if you think about the possibilities now for home care and community-based care, there's a segment of patients who probably would be well served by picking what they get where and from whom. And so while I think I support the notion of coordination and a generalist perspective, the notion of what a medical home is was built on the chronic care model. Not everybody has chronic disease. Not everybody needs a mothership that controls all the aspects of the care. I think we need to think about the medical home relationship to what technology will make possible in terms of, again, patients perhaps having a little more control about where they need to go, how severely they are ill, and a number of other options for coordinating their care where they become coordinators as opposed to someone else becoming the coordinator for their care.
Mark, you bring up an important point. More and more people are going to outpatient surgery centers or different types of settings because they've got higher deductibles or their insurance plan has some kind of a situation where you can get a lower copay by going to these things, different settings rather than a hospital. But what do we know about community clinics? What do we know about ambulatory surgery centers? Do we have some measurements in place, and if not, when will we get some quality information so that consumers can compare various outpatient settings?
Well, we have a fair amount of information on outpatient surgery clinics, and we're beginning to get more information on community clinics as they kind of begin increasingly to be measured by the same yardsticks, HEDIS and CAPS and others have measured mainstream medical care. But I think we go back to what Deborah said earlier about patients being heterogeneous. Our patients, including low-income patients, are all along the spectrum of their capacity to manage themselves, their independence, their reliance on people. And so I think we've got to be careful about specifying any sort of one-size-fits-all medical system for patients who may be in very different circumstances, even within different income groups, and who live in different parts of the country with different expectations for the system.
And Julie, if I could just chime in here, I completely agree with what Mark said. I also think it's important to recognize that what happened with the patient-centered medical home, I think, was that it helped to draw attention to the importance of primary care, good primary care, as the backbone and foundation for helping to get to a place where people are getting the kind of care that they need. I mean, Mark is right. Not everybody has multiple chronic conditions and needs the intensity of care management that we think of as the hallmark of a patient-centered medical home. But we also know that those folks are very much in need, are some of the highest users and highest cost patients that we have. And one of the things that I think NCQA is helping to evolve is our thinking about not just looking at whether or not a medical home or a practice meets certain criteria, but whether or not that you can measure structural criteria or process criteria, but also can you get at some of that less tangible. Is it providing the kind of relationship that engages the patient, that really the patient is likely to change their behavior in, that really is providing the support that the patient needs? it goes back to what I said earlier about as we evolve these new models of care, whether it's minute clinics or patient-centered medical homes or ACOs, we're going to need a new kind of measurement that helps patients as well as others see, are these different models delivering on their promise?
And Peggy, are these models delivering? Do we know? Can we rank them now?
Well, we can't rank them against each other, and in fact, you know, one of our biggest goals is to get some measures out of the patient-centered medical homes that we recognize. Our health plan accreditation includes measurement, and so, you know, we've backed out of some of the standards where we're able to actually measure how well they do. That would be our goal with patient-centered medical homes too. And we have a new recognition program for clinics as well. I think that, you know, part of the difficulty, what Mark is saying is absolutely true. And I think where we see the best cost effectiveness and quality outcomes from patient-centered medical homes is where they've really learned to target the small percentage of patients that need that support, and they don't really bother people that are doing fine. I belong to a patient-centered medical home, and they're not chasing me at all, so it's not a problem. But I think that there are people out there, and I remember when there was a big Medicare health support demonstration some years ago, we were shocked to look at the data at how many people in the Medicare program with diabetes hadn't seen a doctor for 3, 4, 5 years. And they were the people that were right on the pathway to getting their limbs amputated, having heart attacks, having strokes, going blind, having their kidneys fail and so forth. So there is going to be some need for the ability to scan the population and make sure that if people need that kind of support, they get plugged into that, and not waste resources on people that don't need it. So this is a big deal.
And along, you mentioned that CMS and others, there's a lot of government data out there. There's a lot of government quality reports, but private insurers also have their own report cards and their own ways of ranking various doctor groups and that type of thing. Deborah or Mark, I'm wondering what impacts or the commercial quality market, the commercial insurers, what role have they played in the quality movement?
Well, I mean, I'll just say I think that both in the public and the private sector we're seeing movement in the direction of more value-based payment, which is driving changes in the way we deliver care. It's increasing the importance of more and more sophisticated types of data collection and measurement, and hopefully at the end of the day these are going to be models that better meet the needs of patients. But one of the things I think that needs to support good measurement is alignment of payment and metrics across all payers. If you're trying to transform care in a community and you have a number of different private payers in that community, and then you have a state payer and you have a federal payer, and they're all using different metrics and they're all incentivizing different kinds of behavior, you have chaos. You don't have a big push for coherent transformation. And there really needs to be a lot more alignment of both the way we're paying and the metrics that we're using if we want to see all of our different kinds of health providers moving in the right direction.
And Mario, where do you weigh in on that one?
Oh, I completely agree. One of the biggest problems that we face is that we have providers who are pulled in so many different directions. To the extent that we can standardize and streamline things, make things easier for the doctors and the hospitals in terms of the standards and the reporting, we will do a better job of improving quality. You know, you only have so much time and energy that you can focus on things, and when every health plan and the government are pulling you in different directions, you lose that kind of cohesiveness that can move things forward.
We're starting to run out of time here. We're getting very close to the end. Yeah, I wonder if you could chat a little bit about what NCQA plans for the next 25 years.
Yeah, first of all, I just want to thank all the tweeters and note that you've been working their questions into the conversation, and I think it's been a great conversation. So I really want to thank you and our panelists and the people that are watching online and sending in those tweets. We have some exciting events coming up all this year. We're going to have another Google Hangout featuring healthcare disruptors. These are people that are doing things that nobody ever dreamed possible, that are going to change the face of healthcare. That will be in late June, and we'll be announcing that date soon. We have our 25th anniversary gala in Washington, D.C. That's Wednesday, September 16th. And then we have an exciting event called Quality Talks. It's a TED-style symposium in Washington at the museum on Monday, November 9th. And that will be people who we think represent a lot of the future of healthcare, many of the people that are young people and young investigators and who are doing things that are really different and are going to take the journey that we've started and really move it forward. So we're really looking to the future in this event. So thank you so much for being with us. I think the panel was fantastic. And thank you so much, Julie, for being such an excellent moderator.
Great. Well, thank you for having me, and thank you all for joining me. And I wanted to remind everybody who's watching that there will be a recording of this Hangout, and it's going to be available on the NCQA website. So that would be ncqa.org, and that will be available soon.
Thank you.